We are ready to start the afternoon section about the free paper about the valve. Today will be the moderator, also Dr. Chris from Northwestern. He will be the moderator as well. The first the first paper that will present to us today is the aortic valve replacement with the Porcine or Bovine Percardial Valve, the 10 years experience by Dr. Anbarasu.
Dr. Mohan.
From Chennai, India.
Yeah.
Yes, very pleased. And sorry, we have 8 minutes and 2 minutes for the discussion, but maybe we have more because we have just 5 of paper to this section.
Okay, thank you. Good afternoon, everybody. This is our modest experience on tissue valves and aortic portion, our 10 years experience. There are no financial disclosures. The background is that valve heart disease is very common, and especially in a country like India, we have quite a few younger patients coming in, and these patients, when they have a mechanical valve and they go back into the community, the compliance to anticoagulation is poor, and they land up in complications of stuck valve. So we are more liberal in using tissue valves, both in mitral and aortic portion. And the data comparing the porcine and the bovine valve in the aortic portion, especially in the younger population, is a bit sparse. So the aim of the study is to compare the outcomes of bovine and porcine tissue valves in the aortic portion in terms of long-term survival, freedom from reoperations, freedom from non-structural valve deterioration and structural valve deterioration, and freedom from heart failure, infective endocarditis at the end of 10 years old. And it's a single center study. It is a retrospective multivariate analysis study which included patients who were operated between January 2005 till December 2008. We had a total of 154 patients who had a pericardial valve, a carpenterated perimount valve, and a total of 120 patients who had a porcine valve, out of which 56 had an injured bioprosthetic valve and 64 had a Medtronic Hancock valve. So we could totally get 1,100 patient year follow-up on the pericardial valve and a 987 patient year follow-up on the porcine valve. And inclusion criteria were all patients who were above 18 years, and we also included redo surgeries and concomitant procedures along with AVR other than double valve replacement. So exclusion were double valve replacements and mechanical valves. And the surgical technique was pretty much standard. It was a double-stage venous cannula and moderate hypothermia. The CP, the earlier part of the study, we were using blood cardioplasia. The later part of the study, we started using del nido cardioplasia. It was a standard iototomy, and what technique was used was independent to the surgeon. We had a 4-surgeon team operating all these patients together. Some surgeons used mattress pledgeted sutures, some surgeons used continuous sutures. And follow-up strategy with anticoagulation was pretty much standard, usually a 3-month anticoagulation, and then they were kept on a single dose aspirin. And these are the data. The total number of patients were 154 in the pericardial valve, 120 in the porcine group, and most of them were rheumatic. In both the groups, most of them were rheumatic, and the mean age of these patients in both the groups were comparable. It was about 52 years in the bovine valves, in the pericardial valves, bovine pericardial valves, and 54 mean age in the porcine valves. And most of these patients were in class 2 symptoms, and because it's aortic, most of them were in sinus of them, and a significant proportion of them in the bovine valve had a bit of LV dysfunction. And 21 valve was the commonest size used, though in a few patients we had to use a 19 valve. And the cross-clamp time was about 67 in the pericardial valve group and 87 in the porcine valve group. And looking at the results, there was about 3% late mortality in the pericardial valves, bovine pericardial valves, and about 2.1% in the porcine valves. And the structural valve deterioration was a bit higher in the porcine valves, and non-structural valve deterioration was also a bit higher. And that's the linearized rate. And the pericardial valves fared slightly better than the porcine valves. That's the freedom from structural valve deterioration and non-structural valve deterioration. And when our biostatistician could get predictability based on the data we had, and we could, the predictable rate based on the comparative risk regression score was that the porcine valves usually deteriorated slightly earlier than the pericardial valves. So in conclusion, the bovine pericardial valves fare slightly better with freedom from reoperation, structural deterioration, valve deterioration, and non-structural valve deterioration. The limitations were that the perimount valve is right now currently out of market, at least in most of the Asian countries. We still do use a few Hancock and the first or second generation porcine valves. And the follow-up for tissue valves, maybe a 10-year period is not adequate, especially in younger patients. We should have a longer outcome, longer follow-up. And there were different suturing techniques used in by different surgeons, which was not taken into account. And there is no subgroup analysis done between the two types of porcine valves used. Thank you.
Great. Any questions from the floor? Your friend's going to ask you.
Anbarasul, right. Why do you think that there's a difference of outcome? Why the bovine pericardial valves do better? Is it because of the anti-calcification treatment or something? You think so?
We have a similar study done in the mitral portion, a 10-year study done of comparing the pericardial and the porcine valves in the mitral portion. And we published it in the Indian Journal last year. And that is exactly the reverse. The porcine valves tend to do slightly better in the mitral portion compared to the bovine pericardial valves.
But do you think that this is because of the high flow in aortic position?
Yeah, I think so, yeah.
Is maybe that cause?
Yeah.
How does your results compare to what you found in the literature? Because Tyrone David published a great paper on Hancock 2 valves with his follow-up, and this SVD for porcine valves, Hancock 2, were the best I could find in the literature. Did you find anything else that, do you think this is surprising when you look at the literature?
Edwards actually claims slightly better results with the pericardial valves, and they've been contemplating, contradicting Dr. Tyrone David's results with a later generation valve. They claim that the perimount valve is slightly better than the earlier results.
And did you see, what was the mode of failure between bovine and porcine? I think I may have missed it. You may have said it. No,
the mode of failure is as described in literature. The pericardial valves go by thickening, and the porcine valves go by regurgitation, tear and regurgitation. Though in the mitral portion, not in this study, we've seen a few porcine valves surprisingly going for calcification and for stenosis in the mitral portion. A few of the porcine valves, not routinely, but a few of the porcine valves do go in for calcification and stenotic lesions.
Well, good.
Thank you very much. Thank you.
Good afternoon. I'm Do Jung Kim from Aju University Medical Center, Korea. I would like to thank you everyone for the opportunity to present at this conference. I briefly present the findings of our study titled Short-term Clinical Outcomes of Perceval Choice Valve Implantation in 121 cases in a single institution experience. This study was conducted in Severance Hospital, Yonsei University, Seoul. Several studies reporting stress or rapid deployment of aortic valve have been conducted. In 2018, Dr. Consistrel reported on the clinical and echocardiographic outcomes in a large single-center study with 617 implants. Stress valve may reduce cross-clamp and cardiopulmonary bypass time, especially in a combined procedure, and may make minimally invasive aortic valve replacement more easily reproducible. Moreover, AVR using the perceval valve is associated with low mortality rates and excellent hemodynamic performance. Similar results were reported in other studies. Stress AVR is a safe and effective alternative to conventional AVR and is associated with excellent clinical outcomes. Furthermore, this valve may facilitate less invasive approaches, allow shorter operative time, and provide a satisfactory hemodynamic result. We aim to retrospectively evaluate the hemodynamic performance and early clinical outcomes of patients undergoing AVR using the perceval stress valve. From December 2014 to May 2019, a total of 527 patients underwent AVR with bioprosthesis. Of those, 121 patients undergoing AVR using the perceval stress valve. 121 patients who underwent the stress AVR were enrolled in this study. Looking at this figure, the proportion of stress AVR is gradually increasing in all AVR patients in our institution. The primary endpoints were hemodynamics such as mean pressure gradient and left ventricular mass index. The secondary endpoints were early clinical outcomes, including pacemaker implantation, paravalvular leakage, and overall survival. The mean clinical and echocardiography follow-up duration was 14 months and 10 months respectively. Patients' baseline characteristics shown in this table. The mean age was 75 years. The mean Society of Thoracic Surgeons score and Euro score were 4.1% and 3%, respectively. 77 patients had New York Heart Association functional class 3 or 4 preoperatively. This slide shows the operative result. Isolated AVR was performed in 66 patients, and additional concomitant procedures were performed in 55 patients. Regarding the isolated AVR, 27 patients underwent an upper partial sternotomy, a minimal invasive approach. Additionally, the mean cross-clamp time was 32 minutes for full sternotomy and 41 minutes for mini sternotomy. Regarding AVR with the concomitant procedure, the mean cross-clamp time was 79 minutes. The implanted size are outlined in this figure. In this study, hemodynamic performance was assessed at discharge and the 6 months follow-up. The mean pressure gradients decreased significantly from a preoperative value of 49 mm mercury to 11 mm mercury at follow-up. The left ventricular mass index also decreased from 143 to 110 gram per square meter. The hemodynamic results for each valve size are presented in this figure. According to valve size, the peak and mean pressure gradients exhibited significant change from baseline to the 6 months follower. For each valve, the p-value was less than 0.001. Furthermore, the left ventricular mass index at discharge and the 6 months follow-up were consistently lower than pre-operation. Early clinical results showed that 6.6% of patients had permanent pacemaker implantation due to third-degree atrial ventricular blockage. Paravalvular leak was not observed in 98.3% of patients, and 1.7% of the patients had aortic regurgitation grade 1. Valve thrombosis was not observed in all patients. In-hospital mortality was observed in 2 patients, and during follow-up, 1 cardiovascular death due to cardiogenic shock was reported. The overall survival rate was 93.7% at 1 year and 91.8% at 2 years. Since July 2018, we have performed simple technical changes to avoid permanent pacemaker implantation, deeper placement of the guiding sutures in the left ventricular outflow tract may significantly damage the conduction system by placing the guiding sutures no more than 2 mm below the nadir of the annulus to avoid the conduction disturbance. The rate of pacemaker implantation decreased from 8.8% to 3.8% after the technical modification. In conclusion, although high pacemaker implantation was observed, the stress bioprosthesis was considered a technically feasible and time-saving procedure. These bioprostheses also demonstrate a significant survival benefit with excellent clinical and hemodynamic outcomes. Pacemaker implantation has an inherent potential risk in using the perceval valve, and randomized and longer follow-up trials are required to distinguish which specific population will benefit the most from this valve. Thank you for your attention.
Good. Any questions from the floor? Here's one.
Very nice presentation, Dr. Somchai from Thailand. You report the extent of the pacemaker implantation. Do you think it's really from the technique or from the valve, this valve? The cost of heart block is from the suture technique or from this valve itself? The cost of pacemaker heart block, you mentioned about the rate of pacemaker implantation is about 6%. The cost of the heart block is from the suture, the technique of the suture, or from the valve, this valve itself?
From the suture placement or from the valve design? That can cause the higher rate of the pacemaker implantation.
All cases are 6.6%.
Yeah.
But since the 2018 July, we deeper guiding, placing the guiding suture line was placed below the nadir of the annulus 1 millimeter and 2 millimeter. After the modification, the pacemaker implantation had 3.8%.
Okay, so I think that's a clarifying question. So after you changed the technique, the pacemaker implantation rate was 3.8. That's what you said, right? Yeah. What was it before you changed the technique? What was the pacemaker rate?
perceval reference placed it below the 3 millimeter, so we changed it.
I know. So the question, he wants to know why the pacemaker rate is higher. So if you tell us you changed the technique, correct? So what was the pacemaker rate before the change, and what was the pacemaker rate after the change? You said after the change was 3.8. What was the pacemaker rate before you changed it?
Yeah, excuse me. I'm Dr. Singyal Lee, and corresponding order, and I work in the Yonsei University Hospital, and also I'm a perceval international proctor. So 2 years ago, I implanted the perceval sutureless valve system according to the company's guideline, beneath 2 or 3 millimeter from the annulus. So there are very higher instance of permanent pacemaker rate in case of very small body surface area patient. So at that time, I thought that it is originated from the oversized perceval valve could make some conduction block around the right coronary cuspid annulus. However, if we, most common site of making conduction block is the right coronary cuspid area. So before 2 years, I changed the strategy to more shallow stitch. And after that, there was just 4 cases of permanent pacemaker instance. Actually, 2 of them were combined case with myectomy. So actually, there was just 2 cases of permanent pacemaker insertion. So shallowing suture beneath just 1 millimeter from the annulus is very effective for preventing the conduction block in case of perceval sutureless implantation. So recently, I recommended for the all perceval beginner surgeon to make shallow as possible shallow suture beneath the annulus. Okay.
I understand. I'm just trying to find a way for you to make this presentation publishable. So if your hypothesis is that the higher implantation rate will reduce the pacemaker rate, then it would be very interesting if you showed that in your results, that before you did this, that the high pacemaker rate was whatever, X%, and then you changed the implantation rate, implantation technique, and you had a lower implantation rate pacemaker, but that would be interesting for publication. That would be very interesting.
Actually, according to the company's report, the worldwide market of perceval sutureless valve permanent pacemaker instant is around 9% from the worldwide market. However, recently there were many publications of the preventing technique of permanent pacemaker. So 2 years ago, some cardiac surgeon reported about this kind of technique for preventing permanent pacemaker insertion. He suggested that we should avoid too deeply implantation. So at that time, he measured all cases of perceval implantation from the annulus to the end of perceval valve insertion fixation portion. So he suggested that we should avoid over 6 millimeter insertion from the annulus to every side. So many cardiac surgeons already know about it. So we will report about this modification technique. So maybe in this year European meeting, there will be some perceval user meeting and perceval proctorship meeting. So I recommended our modification technique to perceval user group.
The other thing you can do is you just have one group of patients you're looking at. Looks like you have enough of non-perceval valves to make a comparison. Because when you say 6.6% pacemaker implantation rate, that's actually not too bad. You know, that's okay. That's usually it's reported about 4 to 5% for AVR. So it'd be another way to make the paper interesting is to compare your perceval group with non-perceval aortic valves. So that'd be another way to get this a little bit more for publishable. Yeah.
Thank you.
For publication, yeah.
Okay, thank you.
Well, very nice results. Thank you very much for presenting. Yeah, thank you.
Yeah, thank you.
So we moving to the next presentation. Is a bioprosthetic valve really a better choice for the AVR patient on dialysis? Dr. Takeshi Usuka will present this paper.
Sorry, I thought I was going to be a third, fourth speaker. Yeah, sorry. Thank you. I'd like to talk about durability of current tissue valve, especially in HD patient. How to do this? Okay. I do not have any COI regarding my presentation. As background, prosthetic valve selection in dialysis patients is still controversial. Mechanical valves used to be recommended for HD patients to avoid early structural valve deterioration, or SVD, and reoperation, especially in young patients. However, based on the fact that the survival of HD patients after heart valve operation appear to be poor, and the risk of SVD can be balanced with lower risk of major bleeding of bioprosthetic valves, current guidelines do not prohibit the use of bioprosthetic valves in HD patients. According to the recent American and European guidelines, mechanical valves are recommended only for 50 or younger patients. In European guidelines, it's 60 years old or younger. Bioprosthetic tissue valves are recommended for 70 or older patients. And it's 65 years old or older in European guidelines. Mechanical valves used to be recommended for HD patients, but such description was deleted in the recent guidelines. So the types of prosthetic valve for 50 to 70 years old patients are still controversial. And we are not sure whether we can choose the same valve for HD patients whose prognosis is poorer than the non-HD patients. In our institution, we use tissue valve for 65 or older patients, and for HD patients, based on each patient's comorbidities and overall condition, we put tissue valve even for younger patients. This is what valve we use for AVR since 2010. For a patient who is not on HD, tissue valve was used almost 90% of the patients because majority of the patients are old AS patients. Even in HD patients, this choice criteria has been similar. Even if patient is on dialysis, we put tissue valve as we use in non-HD patients. As a result, almost 90% of the HD patients have received tissue valve in AVR. Aim of this study is to evaluate our valve selection criteria is correct or not. We retrospectively investigate our late clinical outcomes and durability of tissue valve AVR. Patients group in our study was consecutive 187 patients who underwent bioprosthetic aortic valve replacement from 2011 and 2019. We compared valve-related outcome among 51 dialysis and 136 non-dialysis patients. These are types of tissue valve we use in this study. As you see in the graph, majority, which is about 90% of patients, received Perimount or Magna or Inspiris Edwards valves. Remaining patients received mosaic or mitral flow valves. This table is about patient details included in this study. HD group was younger and contained more male patients. Serum phosphorus was higher in HD patients. Urgent cases such as infective endocarditis or combined cases were also included. This is about operation details in each group. Isolated AVR was about 40 to 50% in each group. Remaining cases were combined operation. Implanted valve size was same in both groups. Follow-up period was longer in non-HD group. During the follow-up period, 5 SVD were recorded and all SVDs were in HD group. Among the 5 SVD cases, 3 patients received redo AVR. Reoperation was also recorded in non-HD group, but they were all for prosthetic valve infection, and no SVD was recorded in non-HD group. This graph shows freedom from reoperation. More reoperation was recorded in HD group, and the difference was significant. All reoperation in HD group were for SVD. These are operation finding of redo AVR for 3 SVD cases. All SVD cases were relatively young patient aged between 58 to 62 years old. All explanted tissue valves showed similar calcification. Duration from initial operation was 3 to 4 years. In addition to the 3 SVD, which required redo AVR, 2 more SVD were recorded in HD group. Freedom SVD curve was similar to that of reoperation. No SVD was recorded in 136 non-HD group, and the difference was significant between the groups. And in HD group, freedom from SVD at 5 years was only 25%. In addition to the 3 SVD, which required redo, this table is about all 5 SVDs recorded during the follow-up. All SVD cases were in HD group. As mentioned, 3 had redo AVR. In remaining 2 SVD cases, redo AVR was not conducted for various reasons. We picked up several factors which can influence the SVD progression. About age, most of the SVD cases, these top 3 yellow cases, were young patient aged between 58 to 62 years old. Duration from HD initiation was 2 to 32 years, and I can't see any trend or any difference from it. Although all 3 reoperation cases was perimount valve, other 2 SVD cases were not perimount valve. They were mosaic and marginal valve respectively. Although post-op EOAI was 0.78 in one case, patient and prosthetic mismatch or PPM was not obvious in SVD cases in general. And serum calcium was not so high too. Preoperative serum phosphorus was a bit high and poorly controlled in some SVD cases. As I mentioned earlier, most SVD diagnosis was made between 3 to 5 years. We have investigated factors which can influence the progression of SVD. In this slide, we checked young age, which is 65 years old or younger. In overall tissue valve AVR patients, young age was SVD predictor, and it's the same if you investigate only in HD patients. So if you put tissue valve for young HD patient who is 65 years old or younger, you need to bear in mind that the freedom from SVD at 5 years is very poor. We also checked on preoperative hyperphosphatemia. Although it's a predictor in overall tissue valve AVR patients, difference was not significant in HD patients. So we cannot say that phosphatemia is a SVD predictor. The other factors such as diabetes, hypercholesterolemia, male gender, or serum calcium were not significant either. I also want to show the survival curve of HD patient in our study. We compared young HD patient and the older HD patients who had AVR in our hospital. Actually, there was no difference between the groups. Green line is young HD patient and the blue line is older HD patient survival curve. Green line is not better than the blue one at all. So it's difficult to predict HD patient prognosis only by age. As it was reported in other study, prognosis of HD patient is not great and survival at 5 years is less than 50%. Other assessments such as frailty or comorbidities are important to predict HD patient's prognosis. And if you think this patient lived 3 years or longer after the operation, you should think about mechanical valve to avoid SVD. I'm gonna skip this slide. Discussion about SVD cases. Most SVD cases were recorded in young, which is 58 to 62 years old HD patients. All SVD were recorded in 3 to 5 years after the initial AVR. Overall survival after the AVR was not good in HD patients, and tissue valve durability at 5 years was also poor in HD patients. So we think we should consider mechanical valve or redo AVR for 65 or younger HD patients, since insurance doesn't cover TAVI or TAVA in HD patients in Japan. Conclusion, SVD and redo AVR risks should be considered if you choose to implant bioprosthetic valve in young HD patient who appears to have good prognosis. Thank you.
Good. Any questions from the floor? Okay, so those curves you showed, just want to be clear, we're looking at the same thing here. You said freedom from SVD. There's also freedom from re-op from SVD. What were you showing in those curves there? I thought I saw freedom from SVD, but I wasn't quite sure if it was freedom from re-op from SVD, because then you showed slides of cases that you re-opt.
Yeah, but freedom from re-op in non-HD group, there were 2 reoperation. Was it this one? But in non-HD group, they were all for infection. No SVD were recorded during the follow-up. But in HD group, all reoperation was for SVDs.
And how many re-ops were those?
In non-HD group, only 2.
2, and how many in?
135 or something.
And how many re-ops were there in the HD group?
HD group, 3.
3, okay. So I just want to point that out to everybody. You have a huge competing risk here, which is they die. Correct? So here,
right.
I mean, you see here, there's, at 5 years, there's only 1 person at risk. See this over here? In the HD group, there's only 1 person at risk at 5 years. So you only had 3 re-ops. So this sort of curve, this actuarial curve here is a little bit misleading, because it says that at 5 years, there's 30% that, but really there's only 3 re-ops in the entire group. You just told me that, right?
Actually, it's a bit biased by the patients group. We included every aortic valve replacement in this study just to check the durability of the bioprosthetic valve itself. So that we included urgent cases, emergency, infective endocarditis, or double valve or triple valve operation. That's why the survival or the follow-up is a bit poor.
It's really bad, right?
Yeah, it is.
It's really bad. That's why the guidelines sort of changed, because these patients, you showed it, half of them, more than half are dead at 5 years. So this gets back to the argument about whether actuarial or an actual freedom is more pertinent for someone with hemodialysis, because there's such a huge competing risk of death here that sort of this curve, actuarial, is misleading when you look at it, because it looks like, oh, the SVD is terrible here, but you only had 3 re-ops in the HD group, correct?
Yeah.
So I'm just concerned. I'm just wondering whether the conclusions follow from these results here, that you're going to switch to using mechanical valves for some of your
for
dialysis patients.
If patient is in good condition and 65 years old or younger, maybe we should think about it. Yeah. But if patient is in poor LV or very frail, forget about it.
Right. Okay. So if you think they're going to have a long lifespan.
Yeah.
Okay. All right. Any other questions from the floor? This is always a difficult topic on what to do with these dialysis patients. We have one here.
I am Vito from Osaka, Japan, and I'd like to ask about how about the are there any serious complications after the surgery with the mechanical valve patients? You said that about the only bioprosthetic valve group patients. So I want to know how about that?
Actually, I only, I didn't check carefully, but actually the prognosis after the mechanical valve was not so bad. And although the number of the cases were limited, like 10 or 20 patients, but I think most of the patients are still alive without any problem.
Because I agree with it, because in our country, the current control is rather good, better, rather than other countries. So the mechanical valve prosthetic, mechanical valve is not so bad, I think.
Thank you for the paper. Now, apologies for my ignorance. Just for my knowledge, I'm asking, is there any literature on what happens after these patients undergo a transplant? Like they get a bioprosthetic valve, within about 3 months, 6 months, they have a transplant. But does the prognosis improve? Is there any literature on that?
Sorry, I don't have data about I think there's age limitation for the indication of the renal transplant, and I think no patient was for the renal transplant in this group.
Yeah, sure.
So I don't have data.
Sure.
Sorry.
No, I'm not asking from this data. From the literature, is there any evidence to say that these patients with bioprosthetic undergo a transplant and the prognosis and the SVD improves?
I'm sorry, I don't know.
Right, I think I can't give you a number either.
Yeah, sure.
But there's one thing I do think about is if the patient is on a transplant list, that they're waiting for a kidney, correct? And it makes the transplant very much more difficult if the patient's on Coumadin because of mechanical valves. So that's something that I think about when I see these patients, but I don't have a number for that.
Thank you.
Yeah, my name is Olin from New Zealand. I don't mean to gang up on you actually, but I think the chairman point is quite correct in the sense that your conclusion might not be really following your data. If you really look at 3 patients, that you're talking about 6%, right? If you got any procedure done and you say, okay, you got 6% problem risk, you would say that, oh, it's a pretty low risk as opposed to 40% or 60%. If you got 50 patients who've got 3 got into trouble, that's a pretty low number. And another thing we don't know about here is that we don't really talk about the people the burden of warfarin on these patients who got fistula, who need to be put a needle in and out and all sorts of problems. And in our unit, though, we used to put mechanical valve in the past, but we haven't done in the last 15 years. We always put tissue valves in.
But first question, the risks, risk for SVD was, sorry, I can't see. SVD cases were recorded in 5 cases, and the total number in HD group was 50 patients. So during the follow-up, about 10%, 5 in 50 patients. So I think it's a bit high than I thought. And most patients, SVD patients, SVD happens in 3 to 4 years. It's too short. Yeah. So that's why I thought that mechanical can be an option. And the second question, about warfarin, right? I know that there is a risk, especially, HD patient have to get a needle every week. But in most cases, in most bleeding problem, it happens in old patient. Young patient, as far as I know, if warfarin level, the INR can be maintained properly, the risk of warfarin can be balanced with the other thrombotic risks, I believe. But for old patient, you should avoid warfarin.
It's great. It's always a difficult question. Almost anything would do our dialysis patients. Thank you very much. Yeah, thank you. Thanks. Thank you for the presentation.
So we have two presentations left. Both are from TAVI aspect. The first one with the early and the midterm outcome of the TAVI for nonagenarians by Dr. Hiroshi Kurasumi. Please.
Thank you for chairman. The title of my presentation is The Early and Midterm Outcomes After TAVI for Nonagenarians. I have no COI to disclose. Japan, this chart shows the life expectancy of the world. According to the latest WHO's report, Japan has the longest life expectancy in the world. Transcatheter aortic valve implantation, TAVI, is covered by Japanese National Health Insurance since 2013. The widespread use of TAVI and the aging age of the population in Japan have led to an increasing in the number of TAVI cases among elderly patients. In our institution, TAVI is performed even in very elderly patients. The aim of this study is to clarify the outcomes of TAVI in nonagenarians with aortic stenosis. Between 2014 and 2019, 140 consecutive patients who underwent TAVI in our institution were enrolled in this study. We retrospectively assessed the midterm and early clinical outcomes after TAVI in nonagenarian. N group, the patient number is 23 in comparison to those of younger patient. Y group, younger group, the patient number is 170. This slide shows the patient characteristics in this study. The mean age was 83 in younger group and 92 in nonagenarian groups. Preoperative pacemaker implantation rate was about 6% in the young group and 70% in the nonagenarian group, which was slightly higher, but it was statistically equivalent. The other preoperative characteristic was statistically equivalent in the two groups. The STS risk score was 77% in younger group, 8.4% in nonagenarian groups. In this study, 75% of patients underwent TAVI through the transfemoral approach, 90% through the trans-apical approach, 3% through the trans-subclavian, and 2% through the ascending aorta. The balloon expandable valve, which means sapien, was implanted in 92% of patients. The rest, 28% patient was implanted self-expandable valve. The approach and prosthetic valve used, operation time, and blood transplantation rate was equivalent in the two groups. We note excellent early clinical outcome in the two groups. No hospital deaths occurred in the two groups. Although hospital stay was significantly longer in the N group, which was about 19 days. Incidence of any other complication, including newly acquired pacemaker implantation, paravalvular leakage, cerebral infarction, acute type B aortic defection, and other major complications were statistically equivalent between the two groups. This slide shows the result of cardiac function. The aortic valve area was significantly increased in both groups. Peak systolic velocity and mean pressure gradient were significantly decreased in both groups. There were no statistical differences between the younger and nonagenarian group. This is the 5-year survival rate. In the entire cohort, it was 35%. And in younger group, it was 51%. And the nonagenarian group, it was 29%. Survival rate was lower in the nonagenarian group, but they were statistically equivalent between the two groups. The freedom from cardiac event was also equivalent in the two groups. The rate was 66% in the younger group and 69% in the nonagenarian group. They were equivalent. This graph shows the freedom from cardiac death. In this study, there was no cardiac death in the nonagenarian group. It means TAVI may contribute to the avoidance of cardiac death in nonagenarians. We also analyzed the predictor for all deaths after TAVI using Coxing proportional hazard model. Univariate analysis reveals that higher preoperative serum albumin and hemoglobin levels indicate good long-term survival. In conclusion, early and mid-term clinical outcome of TAVI among nonagenarians were comparable to those of younger patients, and TAVI may contribute to the avoidance of cardiac death in nonagenarians. This study indicates that TAVI may be effective even in the nonagenarian population with aortic stenosis. Thank you for your attention.
Any questions from the floor? Were there any limitations from your study?
Thank you for your question. Well, first, I think the number of cases is small. So we don't have no hospital deaths, and maybe good condition nonagenarian only entered and referred to our institutions. I think it's limitation.
Another one is that multivariate regression, the univariate and multivariate. That was risk factors for 30-day mortality or for overall survival?
Overall survival.
Well, then that is interesting to me because you showed that age was not a risk factor for death, which is very, very strange. That makes me question whether or not your multivariate regression was done correctly, because age is always a risk factor for long-term survival.
When you got both old people, it might not make much difference after that. Actually, I find it very interesting because we're also looking at our unit of albumin level and hemoglobin levels for PO patients. I think these are very important. I know some Japanese studies in the community, they look at the albumin number, and they have shown that hypoalbuminemia itself is the indicator of early death. I think obviously this patient has got other issues for the health. So we always nowadays look at frailty, and nowadays we almost become a geriatricians now looking at these old people and doing frailty tests, and none of the frailty tests, they even got the CT scan for the psoas muscles area, not albumin numbers. So I think the pre-op albumin and pre-op hemoglobins are very important numbers. I think you found that is very interesting.
Thank you.
So the question is, did you look at albumin as a risk factor in your group?
Sorry.
For frailty and malnutrition, did you look at factors like albumin or pre-albumin, or did you look at any of those lab numbers?
Any, like number. In our analysis, we just analyze the continuous, we don't analyze the separately. So more than blah blah number is good and less than blah blah number is bad. So I can't say what level of hemoglobin is good and what level of albumin is good. So
I think it's something you could look at. Those are easy numbers to get in your study, but I think it's a nice one. I think I know the reason you did this study. It's because 90-year-old patients think that they're too old for any treatment. You're trying to show that even though you're 90 years old, that we would still benefit from TAVI.
Yes.
I think your hypothesis is good. The results show that, and your conclusions show that, yes, if you're 90 years old, you could still get TAVI. It's a good treatment for you. So I think it's a nice study there. Very, very nice, yeah.
Thank you very much.
Okay, so moving on to the last presentations. Yes, the early and the midterm results of the 87 cases of TAVI in Iwaki City Medical Center will be presented by Dr. Yoshiki Endo.
Thank you for giving me this opportunity to present our report. According to aging era, patients who are suffering from aortic valve stenosis increased, and the indication for TAVI is gradually spread. As we know, the report of Partner 3 trial, which had been published in 2019, recommended that even lower-risk patients should be discussed to perform TAVI instead of AVR. Now, in our hospital, the indication of TAVI is mainly for the patient who is over 80 years old or high frailty scale and suffering from only aortic valve stenosis. We are going to report our clinical outcomes of TAVI. During the period from January 2017 to July 2019, there were 87 consecutive patients underwent TAVI. They were divided into two groups. TF group, in which there are 75 patients performed by transfemoral artery approach, and the TA group, in which there are 11 patients performed by trans-apical approach. We compared these variables between two groups. We also evaluated MASE among the patients. In this report, MASE consists of total death, cardiovascular complications, and cerebral infarction. Our strategy for aortic valve stenosis is gradually changing. We used to perform AVR regardless of patient's age or activities. Since TAVI appeared, our common strategy for AS is still AVR, but the TAVI is getting to be one of the choice of the treatment for AS. we have a discussion among the member of heart team about patient condition, which consists of the age, frailty, other complications, especially other valve diseases. We can recommend TAVI to the patient of high age, high frailty scale, and suffering from only aortic valve stenosis. These are patient characteristics. NYHA in TA group was higher than TF group significantly. The number of patients suffering from CKD is larger in TF group than that in TA group. This slide shows the number of devices used in TAVI. Preoperative computed tomography was analyzed by multi-planar reconstruction. We measure the diameter and the area of aortic valve, height of the coronary orifice, and evaluated calcification of the artery. With these elements, we discuss in heart team. We take into the consideration of the characteristic of valve and the patient's data. Finally, we decide what valve and which size. For most Japanese patients, 23 millimeter Sapiens 3 valve were chosen. This slide shows the result of TAVI. One operative death occurred due to the intraperitoneal hemorrhage. However, the reason was not defined. We protect coronary artery by crossing wire in case that the coronary height was less than 10 millimeter. 9 patients were performed to do so, but no patient was needed to perform PCI after TAVI. 3 cases had access trouble, which PTA was necessitated. With the improvement of device, especially reducing the size of sheath, such cases are decreasing gradually. Regard to the duration of ICU and hospital stay, TA group is significantly longer than TF group. We thought this TA procedure needed to perform left side thoracotomy and place drainage tube to the thoracic cavity. Most patients suffered from pain and had a pleural effusion and atelectasis retained several days post-operatively. These unique elements of TA may affect long duration of hospital stay. Midterm results are as follows. We lost 1 patient due to a prosthetic valve endocarditis. This patient was admitted to our hospital 3 months after TAVI because of fever up. Streptococcus epidermidis was detected by blood culture. Continuous antibiotic therapy was carried out, but the infection was uncontrollable. EVR was performed 4 weeks after her admission, but the patient was dead of MOF in the end. This is a Kaplan-Meier survival curve. There is no difference between the 2 groups. And the result of 2 groups were almost acceptable. As shown before, to evaluate the complications of TAVI, we searched MASE. This slide shows MASE-free rate after TAVI. The results are not significantly different between 2 groups. For the purpose of curing acute heart failure due to the aortic valve stenosis, we performed the balloon aortic valvuloplasty, so it's called BAV. For the patient suffering from acute heart failure, we didn't perform emergency TAVI directly. We performed a rescue valve to improve the left ventricular outflow. After that, medication therapy is performed mainly by cardiologists. Then, TAVI will be performed until the hemodynamics became stable, especially LV function. According to our preoperative research, mostly TAVI was performed 3 months after BAV. This slide shows the LV function recovery by evaluating ejection function in the BAV group. We had checked ejection fraction 6 times during operative period. With the result of our research, the cardiac function was significantly recovered after valve. But after TAVI, cardiac function seemed not to be getting better anymore. The conclusions are post-operative course of TAVI seems to be acceptable. Patient performed by trans-apical approach had to stay hospital much longer than patients of femoral artery approach. TA's unique elements, such as left thoracotomy, insertion of drainage tube to the thoracic cavity, may be the reason why the TA patients stay hospital much longer than TF patients. Preoperative valve is effective as a recovery method for acute heart failure, but the heart function is not significantly getting better after TAVI. To perform TAVI more safety, valve is very useful treatment. Thank you for attention. Thank you.
Are there any questions? I think you need to, so I think it's good to report this sort of data. You got about 70 patients and about 12 patients went transapical. I like that you didn't put stats on it because you really can't say that there's a difference in MACE and mortality when you only have 12 transapical patients. Because if you have one death after 12 patients, all of a sudden it's 9%.
Yes.
Incident rate,
yeah.
Correct? I do have a question for you. Have you considered other alternative access approaches other than transapical? Because the trend now is to get away from any sort of thoracic approach, in particular for patients who are over 80 years old. Have you considered doing other alternative access like a transcarotid or a transaxillary?
Would you repeat the question again? I'm sorry.
Have you done other approaches
no,
other
not
than
yet.
the transapical?
Not yet.
So, question is about the TA approach. All the patient has considered the TF first and not eligible for the TF.
Yes.
And I think you did a lot of the BAV. And do you have any incident had like a massive AR that you need her for support?
Not yet, because the valve is starting the small size of the balloon, and gradually the size is getting bigger. So if the cardiologist, it is a very risky case, we stopped not anymore.
And did you measure the gradient after BAV? Any significantly reduces?
And the amount of leakage of the enhanced agent, the cardiologist had decided the size.
I mean the gradient is reduced after?
Reduced, yes.
Okay.
Yes.
And everyone who got a pre-BAV, did all of those patients go on to get a TAVI?
I'm sorry.
So all the patients who had this pre-BAV, you had a preoperative BAV is effective here. So patients who had a BAV, did all of those patients go on to have a TAVI?
Yeah, you're right. But we had some incidents of valve. So a little bit the risky case we have some experience. So we had all the cases we don't have the valve. We don't do the valve, yes, in all the cases.
Because that's, in order for you to make that sort of conclusion, you sort of have to know how many patients die after the BAV before they could even get a TAVI.
Maybe no patient.
No patient
No
died
patient, yeah.
between the BAV and the
Yeah,
TAVI.
yes.
Okay. Okay, well, good. It's good, always good to examine the results.
Thank you very much.
Thank you for the presentation.
Yes. So I think, sir, we have a good many paper present today, sir, and I think it's time for us Have a good afternoon. Thank you, everybody. Thank you, Dr. Chris, for a great commentator.